So now we have another stalwart in the field of vitreoretina, a teacher by heart, teacher whom you will listen through, and he will be speaking on biosimilar in optimizing DME DR treatment. Over to you, sir.
Thank you, Prashant. Dr. Devdulal has made my life very easy because the topic here was optimizing biosimilars and optimizing DME treatment. This is my disclaimer, my financial disclosure. See, before you say, can you use this drug for a particular condition, you have to say, well, is it as good as the innovator? If it's as good as the innovator, then whatever work is available for use in the innovator can be used for the biosimilar. So the first task we have is it similar? And Dr. Devdulal has already said that, and I can show you the same figures, the molecular weight, the glycosylation, the dosage, the way it is presented, all those things are the same. And most importantly, both are approved by the DGCI. But the approval from DGCI is more important from the fact that the comparison with over here is not with the innovator, but with bevacizumab. And bevacizumab is not DGCI approved, whereas razumab is approved, and that is a very important fact to keep in mind. Now, as far as the clinical trials are concerned, I'm not going to repeat them. These are the same trials which he showed they work. The biosimilar is effective in management of diabetic macular edema. The question is, can I anecdotally support the same with my own work? Well, in addition to the study which we published on this on real life experience with Lalit Verma, this is the cases which I had done individually over a period, consecutive cases of all patients who got anti-VEGF in a 3-month period, and I checked their OCTs personally before and after the treatment. And I decided to see what happens. So there were eccentric patients, Lucentis patients, which means even within that both the names, and razumab. And we found that the number of patients, the proportion of patients who improved, remained stable or deteriorated were more or less similar, no no significant differences in the results. So that gives you that gave me the confidence that we can use the biosimilar wherever the innovator drug is available. So now let's come to the management of diabetic retinopathy. The treatment points for diabetic retinopathy are the earliest stage of no retinopathy or early NPDR, where the mainstay should be medical management, and the conditions where there is a need for active ocular management, that is diabetic maculopathy, proliferative diabetic retinopathy, its sequelae. But this is in addition to the systemic treatment, which must continue. So now, from a therapeutic point of view, in patients who have diabetic macular edema, I believe that those who have leakages within 750 micron from the foveal center, here only pharmacotherapy with intravitreal agents, including anti-VEGF agents and steroids, is the way to go. But in patients where the origin of this leak on fluorescein angiography, that means those leaking microaneurysms are far away from the foveal center, even though it's center involving diabetic macular edema, there the combination of focal macular laser with anti-VEGF treatment is probably the most economic way to manage, and we will see that. The key question regarding which anti-VEGF to use when has come from a combination of studies, including mainly the protocol T, and let us see what we get from them. We do know from the RESTORE study that 25% of patients are those whom we can call elite responders, who do not need injections at month 3 or 4 if they've been given the initial 3 injections. And they have a response which is very good. They end up gaining more than around 2 lines, and they don't need more than 4 injections or so per year. So this is obviously the group which can be managed on ranibizumab alone. The second group of patients, now, when it comes to patients who've got very good visual acuity, the protocol T showed that all the 3 drugs, bevacizumab, ranibizumab, and aflibercept, had virtually the same kind of visual outcomes. But in patients who have poorer vision, aflibercept had a better response as compared to the other two drugs, though the difference between ranibizumab and aflibercept decreases in the second year. Now, the important thing is that even in those patients who were doing equally well in terms of visual outcome, the ones who had very good visual acuity, the response to bevacizumab in terms of anatomical outcome is not so good. You can see it's only around 67 micron decrease as compared to almost 125 micron decrease in the retinal thickness with ranibizumab and aflibercept. So both aflibercept and ranibizumab are equally good for very good vision patients, but bevacizumab is not. When it comes to patients who've got poorer vision, less than 612, aflibercept is the better drug than the other anti-VEGF agents. But even within this now, there are those patients who have a baseline thickness of more than 400 microns. In those patients, aflibercept had the best results. So you have a combination of more than 400 microns retinal thickness with poor vision. The way to go is aflibercept. But what about the patients whose vision is, say, 250 to 399 microns? Here, there is no difference between aflibercept and ranibizumab, and both the drugs have similar results. So this is again a group where ranibizumab can be a safe alternative. Even more important, now if you are talking in terms of monotherapy, yes, aflibercept gives great results. But if you combine focal macular laser therapy with ranibizumab, the outcomes are as good as monotherapy with aflibercept. So if you want to use ranibizumab, then combine it with focal macular laser, and your outcome in these patients with poorer vision would be more or less the same as you have in patients with aflibercept. Finally, we do know that if you are persistent, whether it is ranibizumab, aflibercept, or bevacizumab, the patient continues to improve over 6 months, and that's the basis for the 6 loading doses. Today, I would shift this to a statement which says, if when you give anti-VEGF agents, the patient continues to show you an improvement, either in the form of an OCT change or a visual acuity change, I would persist with anti-VEGF drugs, whichever drug I am using. But if I do not get that response, I would add steroids to that. Here again, so if you have a patient whose vision is less than N8, now keep in mind, we all talk in terms of distant vision. The fact is, if the patient's near vision is affected, this is also an indication for treatment. These are patients who are in the prime of their working age. They need that near vision. So if the near vision is affected or if the distant vision is affected, you need to treat the patient with anti-VEGF treatment. This treatment will continue PRN till either the contour becomes normal. One, the contour becomes normal, and secondly, the vision becomes better than 612 and better than N8. You stop the treatment once this outcome is reached. If it is not reached, you will continue your treatment. And if you don't see any change in the response to 2 consecutive monthly injections, which means 3 consecutive OCTs, that's the time to shift to steroids. I'm going to show you this study, which actually was astounding, and I found it so interesting that I believe it's important for us to be aware of this. This was a study in treatment-naive patients where they used combination therapy with Ozurdex plus ranibizumab versus monotherapy with ranibizumab. And what they found was that the combination therapy got a 21-letter improvement over 1 year. That's something astounding and almost not seen in, I haven't seen that result in any study over the last decade. So the important thing here is that within the first 3 injections of the ranibizumab, they added Ozurdex and then continued with the ranibizumab and then gave the Ozurdex once in 6 months only. The other group got monotherapy. So today, based on what we've got here and what I told you before, if your response to 3 intravitreal anti-VEGF agents is unsatisfactory, that I believe is the best time to add Ozurdex and then continue with anti-VEGF therapy after that. Maybe we find that we get the best results with that. This was a small study and we need more work on this before we can say that this should be the way to go, but it's a way to try. Most important for us is not just the question of whether we can improve the patient. The question is, can we turn the clock back? And this is what we see over here. The DRSS, which is the diabetic retinopathy severity score, compresses the 85-point scale of the ETDRS into a 13-point scale, starting from no retinopathy to severe retinopathy, severe PDR. And what it showed was that you can modify DME, the NPDR with anti-VEGF treatment. In patients who have DME with NPDR, ranibizumab and aflibercept were both almost equally effective in causing a reversal of the disease process, and that is great. In patients who had proliferative diabetic retinopathy with DME, aflibercept was better, but ranibizumab was still not bad at 55% patients who had a regression of diabetic retinopathy. So the thing is, today, we are in a position that we have biosimilars which can help us to optimize costs. Treatment-naive patients can be started on treatment with the biosimilar ranibizumab, which would be optimal for the 25% of patients who are treatment-naive, who did not need the injection at month 3 or 4 and had that better response over the whole year. Those who don't have a response within those 3 injections can be added with a Dex injection, and maybe we get as good results as we've got in this study. This is not comparable to Protocol U, which was recalcitrant patients. These are treatment-naive patients. So just for those who are thinking that Protocol U didn't work. Patients who have a vision of less than 612 with a central subfield thickness of 250 to 399 micron, again, razumab is a good choice for treatment. Patients with any central subfield thickness and poorer visual acuity with economic constraints could still be treated with ranibizumab with focal macular laser. And long-term ranibizumab plays an effective role for regression of diabetic retinopathy, both in proliferative diabetic retinopathy with DME and in NPDR with DME. And that is a thinking we have to now start incorporating. We all think of reducing the burden of edema. What about not taking it out, taking it back? Let's remove the diabetic retinopathy, and that is where we may be able to go over time. Ladies and gentlemen, a judicious use of biosimilar anti-VEGF agents as part of a multi-pronged attack with systemic and local treatment can definitely help to preserve and improve visual function in patients with diabetic macular edema cost effectively and possibly reverse the diabetic pathologic process as well. Thank you very much, ladies and gentlemen.
Thank you, sir, for such a lucid presentation on how to use a biosimilar in the cases of diabetic macular edema. We now need to excuse, sir.
One more question from me. If there is diabetic macular edema, proliferative and PDR, then what should be done? First, the injection should be given or the PRP should be done?
If you have proliferative diabetic retinopathy with surface neovascularization, not raised fronts with fibrovascular proliferation, then you can give an anti-VEGF agent, and I would start the PRP process within the next week after that. And I would complete the
around
PRP.
How many weeks, sir?
Within a week after that, 1 week after
within
that. Because I wait a week because I don't want to use any lens on the eye within that 1 week after giving an injection. And then within the next 2 weeks, I complete the PRP. Now this PRP is a little less aggressive than the PRP we used to do in the ETDRS days, in as much as I leave 2 disc diameter of space on all sides of the arcade and on the disc. That means I have left 30 degrees of the field. So the basic problem that people had, that the field gets affected, which they showed in Protocol S. The field cannot be affected if you leave 30 degrees of field. And that along with, so that's a combination therapy of PRP and anti-VEGF. On the other hand, if it is raised neovascularization, I prefer to complete my PRP first, and once I've completed the PRP, then if it's not regressing, then I will add the anti-VEGF treatment.
Sir, is there any protocol of giving PRP? The gap should be normal one,
Okay.
or
So my gap is actually twice a week. I actually like to do twice a week. I actually do it quadrant-wise, and I finish it in four sittings.
four
That you
sittings,
will all
not the
consider.
usual three
Many
sittings?
people will consider this as very conservative. People like to say I finish in 1 or 2 sittings. I believe when you do less sittings, you can cause less edema, you cause less
Yes, sir.
macular edema. And in patients who've got renal disease, doing too much laser in one sitting can actually precipitate a choroidal effusion.